Welcome everyone this evening to this lecture entitled Managing Presbyopia to its Full Potential. Next slide, please. I'm Dr. Carolyn Major. I'm your host and moderator for this evening. I'm a professor and the director of residency programs at the Oklahoma College of Optometry. Such a pleasure to be here. The next slide. I want to give a special shout out and thank you to our sponsor here this evening. Without our sponsorship, our free CE programs would not be possible. So I want to take a moment and very much thank Lens Therapeutics for their support of this event tonight. Next slide, please. So just a few housekeeping reminders before we get into the meat of the webinar here this evening. So for each hour of CE units, you must be online for a minimum of 50 minutes. For a COPE certificate, you need to fill out the post-session survey. That link will become available in the chat at the very end of the webinar. It will also automatically pop up once the webinar ends. So you need to make sure you fill that out to get your CE credit. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There is no QR code that we're going to display at the end of the session here this evening. So just keep that in mind. There will be no QR code. We're going to email CE certificates within 4 weeks, and we will have a Q&A session at the very end of the presentation. So please put in your questions into the little floating panel at the bottom of the Zoom screen if you're attending from your laptop or computer. Next slide, please. And if you're attending the webinar here from your phone, you can still enter questions using the Q&A little box at the top or the chat with the little bubbles down at the bottom. Next slide, please. Well, it gives me such great pleasure to welcome our excellent speaker, Dr. Shalu Pal. She started and manages the Yorkville Eye Institute in Toronto, Ontario, Canada. She attended Southern College, SCCO, and completed her contact lens, cornea, and disease residency at the Northeastern State University, Oklahoma College of Optometry. And since she's completed 4 fellowships and has most recently graduated from the Global Healthcare Executive Education Program at Harvard Medical School. She is the co-founder of the Canadian Contact Lens Academy, as well as the co-founder of the Staple Program Contact Lens Workshops that take place in North America Schools of Optometry. She's been honored with the CLCS Achievement Award for her educational contributions to industry and awarded the Legends Award by the American Optometric Association. And she was the first Canadian chair of the AOA Contact Lens and Cornea section and the first Canadian selected as a U.S. Contact Lens Institute visionary. Well, Dr. Pal, it's so exciting and what a pleasure to have you here this evening.
Thank you so much, Dr. Major.
I'll let you take it away.
Guys, thank you so much for having me here. You know, I am excited to be able to spend the next hour with you. I want to thank you, Dr. Major, for that wonderful introduction, as well as the WooU team, all those people from behind the scenes that are working hard to make this possible. Thank you for the invitation to be here to speak to all of you, and I'm excited to get started and to dive into conversations about presbyopia. When it comes to my financial disclosures, you know, I really work with a lot of companies, honestly, for my benefit so that I can learn a lot from these companies. I get to learn about new products that's coming out, and I get to learn about what's new in the industry and really help that with my practice and my patients. And I'm excited to learn and share with you actually today the things that I've learned when it comes to presbyopia. So let's dive in. So we should start with talking about why should we even care about presbyopia so much to the extent that we're having so many courses on it? And I think the real answer to that question is the fact that there are so many presbyopes. You know, alone in the US, we've got 128 million. Globally, there's presbyopes everywhere. We know that. So these are people that we need to take care of. And our job as optometrists is to make the lives of our patients better. And how we do that is by taking care of these people and the condition that they're going through. I definitely think if you properly manage presbyopia, it helps to build your practice. And there's so many different ways that you can differentiate yourself. Where I practice right now, there are about 40 optometrists in a 2-block radius around me. So how do we all stand out and how do we all service our patients? Well, we have to find ways to differentiate ourselves and make ourselves unique. I think they're all fantastic, and I'm happy to be practicing in this area. But at the end of the day, we do our job, which is to take care of our patients, and just caring about their livelihood and their lifestyle. That's what this is all about. You know, when we think about presbyopes and we think about who they are, when I started, and it's crazy to say that I graduated 20 years ago, but when I started as a young OD, conversations were different. Presbyopes were different. Today, when I think about my practice, these people are young, they're vibrant, they are not old. I have 50, 60, 70, 80-year-olds that come in that have just spent, their day on the tennis court. They are active, they're fit. These are not people that we think about as old and aging as we once did. We're going to talk about all the different recommendations that are available to our patients today. Glasses, contacts, ortho-case, surgical options, and pharmaceutical options. And I'm going to go through each of these categories with some tips and things that I've learned along the way, and I'll share those with you. Dr. Major mentioned that please, if you do have questions, pop them into the chat. And at the end of the presentation, I'll do my best to answer as many as I can. And if we don't get to all of them, I'll definitely still email you back with the answers. So ask any questions you have, and I'm happy to answer as many as I can. If you've ever seen me talk before, you know how important communication is to me. When I was in school, we had a fantastic communication course that taught us how important this is. I believe so strongly in communication. I think this is how we connect with our patients, how we build trust with our patients. And I really do believe that this solves so many problems when it comes to our associate doctors, our staff, dealing with patients, dealing with anger, dealing with fees. This really is a very, very important skill and tool that we have to work on a regular basis to make sure that our patients are understanding what's going on inside our head and that they understand things in a way that is relatable to them and helps them follow our recommendations. These are two of the most valuable tools that I use. My eye model is literally sitting right here that I use every single day. My marker board, I've actually upgraded it to a boogie board, so that's my new upgrade. But these are two of the most important tools that I have in my practice right now. So why is communication important? Increase understanding by our patients, to decrease frustration, and I'm going to add fear to that. To increase compliance, we make these recommendations and we want our patients to actually follow through, increase our trust, their trust within us, and also to make them happy, right? That's really important. So how do we reach this goal? I've described my exam as my discovery. And I'm very fortunate that I have set up my schedule in such a way that I have 30 minutes with my patients. That 30 minutes is designed for me to spend the time with them to learn about them. What do they need? What are their wants? What are they struggling with in their life? I want to learn everything I can about them. And then at the end, give them a tray of recommendations. I want them to have all access to all the services that we provide in our office, whether it is contact lenses, dry eye treatments, further testing, whatever recommendations it is, I want to then share it with them. And I make those recommendations based on what I've learned about them in my discovery. From there, I then take all of those and we have discussions with the staff. And I do this handoff with my staff and say, hey, this is everything that we've talked about. And now I have taught my staff, what's the next step? To sit with them and go through all the different boxes that we've discussed and answer all the questions that the patients may have. There's a lot. We can do a lot. We have learned so much over the years, and we are so capable of so many different things that we can offer our patients. But in that short time frame, even, I'm lucky with 30 minutes, but in that short time frame, it's hard to answer all the questions that our patients may have. So bringing our team into the mix so that they can then take over for where we left off is super, super important. I can't tell you how important staff are. You have to spend time with them. You have to train them. One of the most valuable things that I have learned is I bring my staff into my exam room with me and I let them hear the way I talk to patients so that they know what is it that I'm saying, so that they can then repeat those same comments with confidence to those patients. Spending time on your staff, educating them it takes time, but it's so, so rewarding, and it will bring so much relief to your timeline that you don't have to do all the work. I never want to be the person in the office that has the most knowledge, because then I become the limiting rate step to this whole equation, right? I want everyone in the office to be able to be helpful. And so when it comes to talking about all our different presbyopic options, I don't want to be the one that has to run behind by explaining the different options. That's where my team comes into play. So this is my practice, and I show it to you for a couple of different reasons. That bar right in the middle there, that is where we actually do the handoff. So where I'm sitting is where my office is, and I come out and we do a handoff to the staff that are at the bar there. And I share with them everything I've learned in my discovery. Now, my practice is in downtown Toronto, in a very posh area of Toronto. And when I came in as a new grad, coming into this area, I was in for a real shock, because I was sitting down as this young new grad talking to our patients about getting old. And they were looking at me like, yeah, we're not going to take this from you. This is not going to fly. I had so many issues. I had people complaining that I gave them readers and now their eyes are getting worse and it's all my fault. I had people not wanting to try progressives. I had people just upset and even breaking down in my chair. They didn't understand what was going on with their eyes. They didn't understand what was happening. They thought there was this change that was causing fear and anxiety in them. And I said, okay, enough. We've got to change how we talk about presbyopia, because this doesn't work. My patients were upset. And I'm like, this is just a natural, normal process that happens to every single one of us, and they don't get it and they don't understand. And me coming in and saying, hey, you're just getting old, that was not working. If anything, that was making them more angry with me. So I came up with this system. And if you've heard me talk about presbyopia, you've heard me talk about the system of 10. And what that is I sat back and said, okay, what is a full presbyope? A full presbyope is someone that has plus 250 diopters of power in front of that they need in order to see up close. So 2.5 diopters broken up into quarter diopter steps. Technically, we're looking at 10 steps of change that our patients and all of us are going to go through over a timeline of, let's say, 30 years, between 40 and 70, maybe 35 and 65, but somewhere in that range, everybody is going to go through these 10 steps of change. And what I started talking about is our focusing system as this reservoir of energy that we are going to slowly lose over time. Okay, so what did that do for us? So let's give you an example. Let's say a patient is a +1 add. So now thinking of our system at 10, technically they are at level 4. They have lost 4 units of natural accommodative reservoir of energy. They have 6 units remaining. I need to give them 4 units of magnification to get them back up to their full potential. If they say, no, I don't want glasses, or I don't want reading glasses, or I don't want progressives, they're going to continue to run on 60%. And when you wake up in the morning and you start at 60%, your system goes, no problem, I can do this. But at the end of our very robust, long, draining day of staring at computers all day, 60% is just not going to cut it. And so what I've taught patients is being at their full potential gets rid of that end of day fatigue. And so it's helped me to start patients in sooner. I've also been able to track with them, hey, you're at level 4 right now. We have 6 more steps of changes to go ahead of us, which means potentially 6 more new pairs of glasses. But at least they understand the process that we're going to, and they understand that it's going to stop when we hit level 10. And I usually get, oh my God, what's going to happen when we hit level 10? Am I going to go blind? No, absolutely not. That's actually a great endpoint where things are going to be calm for a while. You're not going to have this continuous change. I've also seen trends where when you go through levels 1, 2, and 3, it's kind of slow. 4, 5, and 6 speed up a little bit, and 7, 8, 9, 10 go a little bit slower again. So I can sort of track with them where they are in their process. We're tracking every time we do a test and we figure out what their add power is. We just don't explain it to them. And so now I have patients that come in and say, Doc, I was at level 5 last year. I think I've moved up to level 6. There is such an understanding that they're now coming in and saying, I understand what's going on, and let's regroup and let me tell you that I think more change is happening, instead of me having be the bearer of this information that, hey, more change has taken place. I'll also tell you, it really helps me to help them understand what a pair of progressives is versus what a pair of multifocal contacts is, right? Why do I want to start with glasses first before we dive into multifocal contacts? Well, glasses are a linear progression, correct? Whereas multifocal contacts are circular. And I can explain and use this system of 10 to help them understand these two designs. We know with multifocal contacts that this is all dependent on simultaneous vision. When I draw a couple of circles and explain this to them, things start to understand, and it helps with understanding what multifocal contact lenses are all about, right? Simultaneous vision, we are presenting multiple prescriptions to the visual system at the same time and asking the brain to say, turn off those and just use the one that we want. Turn off everything and just use my reading prescription. Turn off the computer and reading prescription and just give me my long distance because I want to see far away. That's simultaneous vision, which is very different from a progressive, which is look here and you're going to get distance. Look down here and you're going to get reading. Two different brain processes completely. And being able to explain that to patients helps them understand why you don't want to rush into two systems right away. So let me give you another example. Let's say you have a patient who has a 150 at. They've now lost 6 natural units. They've got 4 remaining. I need to give them 6 units of magnification to get them up to full potential. Now, if I draw out what a progressive pair of glasses looks like, distance, reading at the bottom is distance plus 6 units of magnification. And I can draw this out in terms of the increasing in add power as they go down. We can do the same with a multifocal. This is an example of a center near design, distance on the edge and reading come to the center. Okay, so why is this helpful? Now, imagine someone starting at this lens at a level 2. We've got 3 gradations in that pair of progressives. Why, if my friend who started these glasses hates her progressives? How old's your friend? Oh, she's 65, she's 70. Okay, well, they probably started at a level 10 and went from single vision distance to now having 11 gradations in that lens. How is that an easy jump from one to the other? That's probably why it didn't work. But you're only at level 3, so there's going to be less going on in that lens. And next year, when you increase and we just need to add a layer, adaptation is going to be so easy for you. And you're not going to struggle the way that someone else did that waited until the very end to make that big jump. It leads right into the importance of why we should start early. Whether it's with progressive glasses or multifocal contacts, the sooner you start, the less gradations are in that progressive pair of glasses. The less gradations are in that multifocal contact lens, which makes it easy for us to give them 20/20 vision in all ranges. It makes it easier for the patient to adapt to these different designs that are new to them. And I just don't see the advantage of waiting and stalling and waiting and waiting. We've got great products in both categories that we shouldn't wait. We should be starting earlier with them and taking away this longer period of adaptation and struggling and likelihood of having redos and having them come back complaining, I don't like this. I want you to think about this system of 10 when we talk about anti-fatigue glasses, okay? Think about who were these anti-fatigue glasses generally made for? These were our young teenagers, these kids that are staring at phones all day long. We're giving these beautiful long-distance prescription glasses, and then they're staring at their phones all day. So when we think of that system of 10, they have all their 10 natural units there. They haven't lost anything, but what we're doing is we're giving them an additional boost of 2 extra. So what are you explaining to our parents? You're saying that extra boost is giving them some flexibility so that they don't get so fatigued by the time they're in their late 20s, early 30s, that they're just exhausted. We're just trying to prevent the strain at the end of the day because they're doing something that this focusing system was just not naturally designed to do, which is be constantly used all day. So I'm using the system of 10 to also talk to parents about their kids. The thing is that this whole conversation about accommodation and this reservoir or energy, when you talk about it earlier, then you don't have to have these conversations about aging. You're talking about a muscle, you're talking about energy, you're talking about this reservoir that we are naturally losing, and how do we preserve it as long as we can. So I want to shift our thoughts again. We refract people to 20 feet away, and patients sit in front of devices all along. So we give them these beautiful long distance refractions and glasses. And then we say, okay, now focus through that and do all this work to change that long distance prescription to an up close prescription so you can see your devices all day. It's really having a toll on our system. And I really think if you start talking early and stop talking about this aging thing, we can start talking about it sooner, but we can also start blaming what's happening instead of on age on something else. And we can start blaming it on all these digital devices that we're all now sitting in front of. So thinking about how do we prevent presbyopia from setting in earlier? How do we prevent the fatigue? How do we prevent the obstacles that are coming, that we know that are coming? All right, let's dive into spectacles. Okay, when we think about spectacles, I want to give you some of my favorite tips. When I started in this practice years ago, it was, hey, do you have a computer? That's what I was asking my patients. And now it's, tell me your cave setup. How many monitors are you looking at? How many laptops? And I'm trying to understand what the dynamics is of their setup. So it's part of my natural case history to actually ask them, tell me what your computer setup is. And you can't see my exam right now, but I have my laptop here and I have a monitor here. I have a Mac and I have a PC, and I have a setup that I can use to help these patients. One thing for sure that I always do is we don't prejudge, and we always make the best possible recommendations for our patients. That's 100% what we should always do. Never be thinking about what's the least costly option. You want to just give them the best, because that leaves you unbiased. You want to come off as, I'm hearing you, and based on what you've told me in my discovery, I'm going to give you the best possible options. And then you're going to do a great refraction, and your refraction is the best refraction, not somebody else's, it's yours. And the best two tips I can tell you here is make sure you balance people and you do a plus buildup. It's to avoid over minusing them in the distance and then them having to sit in front of a screen all day and having to accommodate through that extra prescription that was overprescribed to them. So a binocular balance and a plus buildup, super, super important for you to do. One of the other things that I do with my spectacles, and I've been doing it since day one, is I include all of their coatings. And way back when I started, it was when labs would say, let's talk about how many of your patients are in anti-reflective coatings. And I thought, why is not everyone in an anti-reflective coating? I'm just going to include it, and I'm not going to have this be an upsell because I think it's important. UV protection, anti-reflective coatings automatically go into people's glasses. It's not an option. It just is what it is. And I'd have reps come back and go, how do you have 100% penetration in anti-reflective coatings? And I said, because I don't give them a choice, because I believe it's the right thing and the best thing for them. When I see someone on Zoom and you see all the reflections on their glasses, I'm like, oh my God, how did they not have AR coatings on there? But every time you ask a patient to upsell to something, you're going to lose people. So my philosophy was to do the right thing and include it. And instead, the conversation is, did you know, here are all the things that your glasses come with, and they are included in it. Oh, that's great. That's great. They have this and this. It's a different conversation than, here's your bare bones, and let me add, right? Then it's this game of, oh my God, how much more are you going to upsell me, right? Flip it, make it more of a positive. And the other big thing that I do is I trial frame. That environment that I have here, I talk to my patients, I find out what they have, I have them sit in my chair, and then we sit in front of the laptop, or we sit in front of the monitor, and I'll trial frame the different refractions. Two reasons. One, most people don't do this. So they feel like, oh my God, I get to see what this is going to look like before I buy my glasses. It's also helping me to reduce any redos, because if they're like, something feels off, great, let me troubleshoot that now while we're in the exam room before you've actually purchased a pair of glasses. And I always allow time for questions. Regardless, sometimes I'm rushing, but as we're walking around, please tell me, do you have any questions? Because I don't want to rush this if you do have questions. It's super, super important you give that. The difference between progressives and computer glasses I started talking more proactively about these because I had those patients come in where I wasn't talking about what's your environment, what's your laptop setup, monitor setup. And I had people coming back and I said, okay, I've got to change this conversation because we're having too many people coming in going, I'm doing this all day and it hurts. When I started, we didn't have these massive monitors. They were sitting below and everything was looking down. Different now, right? So when I talk about progressives and I talk about computer progressives, I talk about long distance at eye level. Down below is your laptop prescription. I don't call it intermediate, I call it laptop. And then I talk about reading down below. And then they say, well, I'm not using a laptop, I'm using a monitor. This pair is not going to work for you because at eye level, you need a different prescription. And what's at eye level is your long distance. And when I have them sit at the monitor and they say, oh, you're right, I'm staring at eye level. And then I show them, let me show you what your computer prescription is. Then they get it. It visually connects. They're hearing it, they're seeing it. It all makes sense to them. And so I have now people understanding what the difference is between a pair of computer progressives and a full progressive. And I say, basically, we chop off the distance and we expand the rest. So your computer prescription is at eye level. So you're no longer going to be doing this head bobbing situation. They may still say, great, I'm going to actually lower my monitors and I'm just going to stick to one pair. No problem. But at least they're not going to sit at home and go, these don't work. She told me they were going to work and they don't work. It's now, I see what she was talking about. I need to come back and get the computer progressives, right? Better understanding, less frustration. They're getting what they need and it's saving us all time in the long run. What if they refuse progressives? What if they're emmetropic and they're just not ready for all of this? What if their night driving is an issue? Still, what if the near is just not enough and they're not happy with what they're doing or they're struggling a little bit? What if there's glares, halos, shadows? What if these are still issues? What do we do in these situations? Well, this is where we think about what else is available to us. What other tools are available? You've got contact lenses, GPs, hybrids. You've got higher order aberration correction. And we also have pharmaceutical agents that we can talk about and think about for these different scenarios. I'm planting some seeds here and we're going to come back. Let's talk about contact lenses. What are the advantages of having contact lenses and fitting multifocal contact lenses in your office? Patients want them. They want them. And they are going to leave your practice if you don't offer them. And how do I know that? Because I have patients that come to me that say, my doc doesn't fit multifocal contacts. And I'm like, who's your doctor? And I'm like, they do. They just didn't talk to you about it. So patients want this. They want the functionality. They want the different ranges of visions. They want to be hands-free. You know, having glasses and readers, it's not always the beneficial tool for them. They want to feel young and they want to feel like, I always did this. Why can't I just keep doing this? Make my life easy for me. Well, we can because we have great products. We have great products. And how communication fits into this? Communication, the most important things that I want the patient to know is when we're fitting multifocals, what's my timeline look like? What does adaptation mean to all of this? What are my expectations for you? If we are starting early, my expectations are quite high. If we're starting with a +2, 225, 250 ad, I've got to set more realistic expectations. And I'd rather set the bar low and then supersede that and make them so happy with what we are able to do than to disappointment that we didn't reach those goals that they have. Expectations really comes from having those good conversations. What are the reasons why people drop out of contact lenses? It's discomfort, dryness, and a lack of capability of vision. And so a couple of things here. 100% we know that contact lenses are going to create dryness. 100%. There is no doubt about it. It's just a matter of when. So when I think about that, I think about habits and I think about a brand new contact lens wearer and what is it that we are trying to achieve for them? There are two parts to this relationship. One is the cornea, one is the contact lens cornea, right? I want to make sure both are okay and I'm looking at both. So make sure you check the cornea for dryness and Help the contact lens though along the way. Help yourself along the way by getting your patients from day one to start using moisturizing drops. I use moisturizing drops every time I brush my teeth to keep my contacts and my eye lubricated to prevent long-term dryness. 5 years, 10 years down the road, now your patient is struggling with dryness and they can't wear contacts anymore. And now you're like, change the routine that you've been doing for 10 years and let's start putting a drop in there. They're going to be like, yeah, I haven't done it. I can't. But a patient who's been from day one, been taught to use eye drops, it's going to make their life a lot easier. So why don't multifocals work? You know, we can have an entire conversation on just this alone. If you follow the fitting guide and you do all the steps correctly, you do a great refraction, you choose the right lenses, you give them time to adapt, you're going to have a very high success. And I'm talking whether it's soft, GPs, hybrids, sclerals, there are fitting guides for all of those. And if you follow them correctly, and let me add to that, if you start early, you're going to have great success. Sometimes the design, maybe you just have a faulty design. Sometimes they can't adjust because their brain is saying, yeah, this just isn't working for me. And that's where you start to adjust the lenses and you adjust. And the way I want you to think of this is that complex design, we have to move those rings in and out by adjusting the sphere part of it so that their brain can catch simultaneous vision. That's what you're doing. Stop thinking about this in complex optics forms. Think about this of a complex design of rings that you move in and out to get the brain to understand simultaneous vision. That's what you're doing when you're adjusting the lenses. Maybe it's just a poor fit. Maybe you have a defective lens. Maybe there's residual astigmatism. Maybe pupils are an issue. Let's take a tangent and let's talk about pupils for a moment here. Let's see if this is, so this is one of the devices I have in the office that helps me measure pupils. But pupils are really, really important in this conversation. Let's think about the triad for focusing at near. We accommodate, we converge, and our pupils shrink, right? And when we think about a pinhole effect, we've all done it. We've all handed our patients a pinhole to see, can we improve vision with this pinhole? What happens? All that stray light now comes in and we get light coming in right through a much smaller opening. It's really important. How are we doing that? How are we helping to focus light? We're doing it with a smaller pupil. What else do we think about? What else do we know about pupils? When you have a smaller pupil, you're going to increase the depth of focus. When you have a smaller pupil, you're going to reduce your higher order aberrations. If you've ever had a patient that complains of halos and glare and you give them a pinhole, they go, oh my God, it's all gone. You're reducing all of those higher order aberrations that are sitting out there and all the rays of light that are coming in at angles that are creating those distortions. You can reduce all of that by impacting the pupil and the size of the pupil, right? So pupil size is important. So how do we alter pupils? I'm planting another seed about pharmaceutical agents here. Let's talk about misalignment. Our line of sight and the geometric center of our eye don't always perfectly line up. And in the past, I would see this because my patients or my staff would put a patient in a topographer and go, okay, I want you to look up 2 rings or over 2 rings, and they would have to try and move them in order to get lined up so the rings were centered on the cornea. And I would say, they're not lined up. Their angle kappa is too big. Well, how does this impact what we're doing with multifocals? Think about this complex multifocal design that we're hoping will line up perfectly with their pupil. And if they're not lining up, what does that do? And I started looking at pupils a lot more once I knew that I could do something about it. And I started to notice that people are either very much lined up or the majority of their pupils are sitting up and in ever so slightly. And I was like, oh my God, I'm going to start looking at pupils, because if their pupils are not lined up with the center optics of a multifocal contact lens, we're going to get all of these issues. There's devices that will help you measure misalignment, but your slit lamp is great enough. You just have to look and see where the center of their pupil is. One of a really cool trick is using your topography, if you have one, to take a topography of the cornea. And I want you to look at your tangential maps. And then I want you to put a contact lens on top of the eye and do another map. Again, looking at the tangential maps, and then do a difference map between the two. And then you're going to see with that map, where is the add power of that multifocal? And if that add power is not sitting on top of their pupil, it's more here, you know that your optics are misaligned with that pupil. So I want you to be thinking about misalignment, and maybe a multifocal fit is not going to work if you're not misaligned. Impacts of misalignment, think about creating more distortions, creating prismatic effects. Think about higher order aberrations and blur and glare and halos and all of these things that your patients complain about. And you're like, why are you complaining about this? I want you to look for that misalignment. Thinking about higher order aberrations, it's a hotter topic these days. We have an ability to measure, we've had ability to measure aberrometry and higher order aberrations for a long time. We haven't had the ability to do something about it. I think the most important thing that you need to know about higher order aberrations is aberrations come from the front surface of the cornea, the back surface of the cornea, and from the lens and the crystalline lens. You can have misalignments in any of these different layers, and collectively, all of that through all of those pieces is where your HOAs are going to come from. Okay, so great, I can measure this and I can say, okay, your ghosting is coming from this measurement, but what can we do about it? Well, scleral lenses have the ability for now you to be able to put higher order aberrations into them. You can also decenter the optics. So if your center of the optics is sitting here and your pupil is here, you can move that center of the optics to where the pupil is. You can put the higher order aberrations on there. You can put multifocal designs on there. Where we have come from where we used to be, there's so many options out there. And I want you to be thinking of, why is this not working and what else can I do in the world of contact lenses to help give my patients better vision when it comes to multifocals? And when you start correcting all of these, I had a patient who was wearing multifocal sclerals. She had 2 multifocals and I couldn't get them to work. And in the dominant eye, I ended up going back to her single vision lens. So I did a modified monovision setup where we had a long distance lens and a multifocal in the non-dominant eye. And as soon as the ability to be able to decenter the optics became available, I said, we're going to try multifocals again. She's like, I don't think it's going to work. I said, please let me try. We tried. We put the decentered multifocal over that right eye. And now she's like, this works. What did you do differently? And the thing is that I induced so many aberrations by putting a multifocal on her eye that wasn't centered, that's where she was like, I just can't tolerate it. I think an important thing I need you to all hear me, because when I heard this, it was kind of like a light bulb moment for me. Every multifocal that we put on a patient's eye, contact lens multifocal, we are actually inducing more aberrations. How come? Well, we're putting multiple layers of prescription in front of them, and with their glasses, they're used to one prescription. So with one prescription, they see great. And with now all of these layers, we've induced more aberrations into the system. We are technically making our aberrations worse. So you also have to factor that in. And that's where setting the right expectations is really important. So what else can we do in this situation? If all of this you've done higher order aberration corrections, you've used multifocals, you've decentered the optics, and the patient's still not happy, I think you got to get new patients. Just kidding. I think this is where it comes back to realistic expectations, right? Setting those realistic expectations, but also now thinking about pupil size. Where can I customize the pupil size in these special designs? And maybe should I be thinking about pharmaceutical agents when it comes to these contact lenses? Maybe I'm working with a soft contact lens. I'm just not getting enough add. Maybe these pharmaceutical agents can help me here to just give me that additional boost that we're looking for. Lines I want you to remember, the goal is to meet most of your needs most of the time. You may need to give up a little bit of crispness for some freedom. And this is the best that we can achieve, right? It's okay to hit a point where this is the best that we can do, but just make sure you ask your patient if they're happy, because that's a really more important question than constantly asking, what can I do better? What can I do better? There is so many more things that we can do to help our patients. I just want you to be creative and keep thinking about these seeds that I'm planting. All right, let's talk about Ortho-K. So Ortho-K, I do a lot of Ortho-K fitting, and I have done monovision where I've given long distance and a little bit corrected fully the long distance, and I've undercorrected the non-dominant eye to give them a monovision impact. Or maybe we're just putting one lens in the eye on the dominant eye to correct the distance, and the uncorrected eye is giving them enough reading. That I have done more of. But presbyopic correction, there are people out there that are doing and using Ortho-K to correct presbyopia this way. I haven't done it, but again, thinking outside the box, there are other things that you can do. And it's a great thing to be thinking about. How do I think outside the box and how do I do things differently? In Ortho-K, what if they're not satisfied? What if they are in the best possible correction that you can do, and we're still not achieving the amount of ad that we want? Besides switching to a whole new different platform, this is again where we're planting seeds that maybe pharmaceutical agents might come into play and might be able to help us here as well. Let's talk about refractive surgeries. When it comes to refractive surgeries, you've got lots of options. And in my practice, the real lens exchange is where we're doing basically cataract surgery early in advance of them actually having cataracts. And you've got lots of different IOL options. Think about these. I talk a lot about these. My patients and their expectations have changed from 20 years ago. What they want from their vision is dramatically different. We used to wait until people were like 20/80, I'm still good, I don't need it. And now it's 20/25 vision, and it's like, this isn't good enough for what I need to do with my job every single day. This is a conversation that's happening a lot more. We're going to talk a little bit about managing those patients. When it comes to corneal surgical options, you've got options. You've got monovision, you've got LASIK, you've got the camera inlay. The camera inlay was used for a while here in Toronto. It's not as common as it once was. PRK, LASIK, there are different options that are available. I would say that for me and my practice, I'm going more with the IOL implant options since the IOL multifocals have become great. And when I'm thinking about who's a good candidate for these type of lenses, I'm thinking about, were you successful in multifocal contact lenses? Yes, then you are someone who adapts to simultaneous vision. And if you've got great success with that, this is going to be a great potential jump for you. When you've never been successful with multifocal contact lenses, I'm going to be a little bit more hesitant to do something like this permanently. You have scleral surgical options. Now, this is something that we are not seeing a lot of in this era, but there are options that are available to you here. I want to talk about how you co-manage these patients, and finding the right candidates is super important. And that comes from your discovery and having good conversations and knowing who your patients are, understanding what their expectations are, and having those great conversations. But something else that I do is when I'm talking about any type of surgery, whether it's corneal surgeries, cataract surgeries, it doesn't matter. My conversations and how I communicate with them is about the entire process. I am talking about the job that I am going to do before they get referred to surgery, what's going to happen at their consultation, what's going to happen during surgery, and what's going to happen after surgery. It's one big package that we're talking about. And the reason for that is because I want them to understand that cataract surgery is not just the part of the surgeon, it's about the whole process, what I need to do for them in my pre-workup and what I need to do in my post-workup. In my pre-workup, I'm obviously checking all of their health requirements. I'm checking if they have dry eyes, and I'm managing their dry eyes before we're going to put them through something surgically, because I want them to have the best outcomes. We know that if you have dry eyes, you can have up to 2 diopters in error in your IOL calculation. Why would you ever send somebody for this type of a surgery without checking their dry eyes and then managing their dry eyes before you send them? So talk about the full process and set them up for the greatest amount of success, because if they fail at their procedures, they're going to end up back in your chair and they're going to want you to fix it. So you're also helping yourself and helping them in this whole process and preventing those downfalls and those issues that could come up. Okay, so what happens if surgery doesn't go as expected? What happens when there is trauma or ectasia or scarring? What are our options for these presbyopic patients? Okay, well, post-surgery, you can look at everything: glasses, contacts, GP, sclerals, HOA correction, decentered optics, pharmaceutical agents, right? Think about all the tools that you have in your toolbox to be able to manage these patients in a level that's more. Give them more options. Don't give up on these people, because I think that's one of the most frustrating things of presbyopes is they feel like they're just in this alone and struggling. And I think about my own journey with presbyopia and how I started and where I'm at right now. And I remember going to one of my really good friends, and I'm like, something's wrong. I've got these crazy headaches. I don't know what's going on. And we were going through it, and he starts laughing. He goes, dude, you're just getting old. I'm like, don't say that to me. I'm not getting old. And it was just that. It was just the start of presbyopia for me. And it was a not fun experience. And I struggled, and it took me forever to clue in that that's what's happening. So we need to do better for our patients, because that's with us having knowledge of what's going on and still feeling that fear and lack of understanding. Okay, let's dive into pharmaceutical agents. So when it comes to these pharmaceutical agents, you've got a couple of modes of actions. How are these guys actually working? You've got a category of agents or of medications that work on the crystalline lens, keeping it more flexible, preventing it from getting stiff so it can still continue to accommodate. Then you have other medications that work on the iris sphincter to cause the constriction, to create that pinhole effect, to increase that depth of focus, to give them more reading ability up close. Now you've got a couple of different categories of medications in this category here, and we're going to talk about them. We have non-selective and selective. So we're going to dive into a little bit deeper here. But I've worked on this grid here a little bit and taken it from a couple of different places and added to it. And I wanted you to see all of the different medications that are currently available or that are in the pipeline or that are in clinical trials. The first row, we're talking about a medication that's designed to work on the crystalline lens. Your next big category all the way to the bottom are all the miotics that are working on the iris sphincter. The ones in the middle that are all light blue, all of those are non-selective. And I'm going to explain what that means. And then the last one is a selective miotic. And we're going to talk about what that all means. What's really interesting is when I think about being back in school, all of this neuro stuff was just, I'm not a neuro-optometrist, and there are great neuro-optometrists out there, and I am just not one of them. So this was always something that I laugh that I'm now talking to you about it, because I struggled with this. And so the people that sat around me in class who would explain this to me over and over again, I think I finally get it, maybe. So when we think about, and I want to break this down for you. So when we think about what the mechanism of action is for these miotics is they're muscarinic cholinergic receptors, and they're agonists that work on those. So they work on these special type of receptors, and they are agonistic. So let's break down these words and understand what that means. When you think about muscarinic or nicotinic, you're thinking about the parasympathetic system versus the sympathetic system, okay? So muscarinic is the parasympathetic. This is your relaxed state, not the fight or flight. And this is what's working on the iris to cause that constriction. The cholinergic receptors are found on both the iris and the ciliary body. And this is important that these are found on two different places inside the eyes, okay? The next is agonist. We have agonist and antagonist. Miotics that we're talking about are agonists. Agonists help the action, the intended action, to actually come to fruition. So the iris wants to shrink, it wants to constrict, and we are helping it do that. An antagonist is what our dilation drops do. They force and go against what the natural path is, and they block the regular pathway, and they cause dilation. So these miotics are the parasympathetic pathway. They work on receptors that are both at the iris and the ciliary body, and they cause the regular action that they want to do more of. Okay, so what happens when we use these agonists, and what's really happening? So let's think of one of the positives that we want is we want constriction to happen. So that's one of the positives that we do. But some of the negatives is we don't actually want these to work on the ciliary body, because when you start causing this action, this agonistic action on the ciliary body, you get the ciliary body to spasm, and that can create headaches. It can create myopic shifts. It causes the lens to displace, which can potentially cause retinal traction, retinal detachments, posterior synechia to form. So that's all the bad stuff with activating these receptors. All of those medications that we talked about were non-selected. They don't differentiate between the iris and the ciliary body. They work on both of them. And so when we think about all of those, I'm going to go back here. When we think about this grid here, so many of these are pilocarpine, right? Different variations of pilocarpine. And let's jump ahead. When I was chatting with a lot of doctors and we had a pilocarpine that became FDA approved and available in the US, I said, tell me about what your experience is. And a lot of them were very excited about trying this in all of those different scenarios where we could potentially use this, but there were so many side effects. And the problem with the side effects is that, yes, it was helping the iris to constrict, but it was always also having this impact on the ciliary body. And that was creating problems. And what ended up happening is that people would try them and the patients would be like, great, yeah, but no, I don't want to do this again. And ODs were not happy because they were like, we're creating a potential risk here. And there's all of these side effects that I'm not sure if I'm comfortable with. So we have a new kid on the block. And the acetylcyclidine is a new medication that's not FDA approved yet, but it's been put into and their FDA application was just put in a couple of months ago. But this is different. This is different because it's selective. It is only working on the iris sphincter, opposed to working on both structures. That's different. That's different than what we've had in the past. So when we think about what's possible with these medications, we have a better safety protocol. We have something that in the clinical trials are showing some really great results in terms of the duration, the efficacy, and creating that pupil size that we want. So remember all those seeds that I was planting of where this can be used? I want to review that list and go through this and remember that, hey, you know what? When we have access to this and when it becomes available, here are all the different places where we can start thinking about how do we use this? And thinking about when you're seeing patients and seeing presbyopia patients, what are my other alternative options that are available to me? And knowing that this is around the corner and hopefully we'll have it soon.